Hello, my name's Christina Rogalski. I'm a genetic counselor at the Cleveland Clinic, and today we're going to talk about familial thoracic aortic aneurysms and dissections. As I said, my name's Christina Rogalski, and I've been a genetic counselor at the Cleveland Clinic for over 10 years. My main role is a clinical genetic counselor, and I see a variety of cardiovascular indications. I also have a role in research where I'm a coordinator of numerous pulmonary hypertension studies. I do work both with clinical geneticists and with the providers in the Heart and Vascular Institute, so I really see myself as a bridge between the two. I see how both work and how both groups provide good and distinct information to inform how the patient should be cared for. So through this course, I hope that you will be able to identify the variety of genes associated with thoracic aneurysms and dissections and appreciate the spectrum of clinical findings that we can see in genetic aortic disease. In particular, there are numerous syndromic causes where we can identify some features that help us recognize what these conditions are, as well as some findings in what have been termed the non-syndromic cases, particularly the cases not associated with hereditary connective tissue disorders, that can help us really have a clue that something genetic might be going on in a particular patient. So let's start out with what we know about the genetics of thoracic aneurysms and dissections. Well, we know that about 20% of thoracic aneurysms and dissections are familial. And what is really important is to make sure that these family members are actually getting evaluated. So our first recommendation when we see a patient, or when I see a patient who has a thoracic aneurysm of unknown cause, is to recommend that all their first-degree family members, their children, their siblings, their parents, get an echocardiogram to assess their aortic measurements so that we have an understanding if there's no prior known family history, is it something that we're dealing with here? And if it is, then we can get the patients in to be evaluated and cared for appropriately. And that really is our standard approach, because we know that only about 20 to 30% of the genetic cause of thoracic aneurysms and dissections are currently known. So we know that even though we do utilize genetic testing to try to help us identify other family members at risk and to care for the patient, we know that often, even by doing that, we aren't going to come up with a cause. And then we know that we rely back on the clinical cardiology evaluations to help assess who might be at risk in the family. We know that the known genetic cause can be very helpful to us in managing these families, but we also know that there's still a lot yet to be known about the genetics of aortic aneurysms and dissections. The majority of the time, these families have inheritance that are autosomal dominant in nature, and only a minority are associated with recessive inheritance. And that's, again, why it's so important for all first-degree family members to be evaluated. So there has been an explosion of understanding of the genetic nature of familial thoracic aneurysms and dissections over the last 10 years. That really started in 2005 when TGFBR2 and TGFBR1 were shown to be associated either with, depending on who published it, Marfan syndrome 2, Loeys-Dietz, or familial thoracic aneurysms and dissections. And by identification of those genes, it actually propagated throughout research, and many more genes within the TGF-beta pathway were identified to cause familial aneurysms and dissections. And then there was also this growth of what we've termed the nonsyndromic familial aneurysms and dissections, with ACTA2 and MYLK and MYH7 being identified to cause these cases of aneurysms where it wasn't particularly a connective tissue disorder or connective tissue findings associated with these families. So overall, in the past 10 years, we've had rapid growth in the identification of genes associated with the aneurysms and dissections, and we have been rapidly trying to make sure that we know how best to manage these patients as well. So these syndromic cases, largely these are made up of hereditary connective tissue conditions, although there are some other syndromes that lead to a higher risk of aneurysms and dissections. But what I have highlighted here are the most kind of commonly identified, although they are all rare, but Vascular Ehlers Danlos syndrome, Marfan syndrome, and then these genes on the right that are highlighted are Loeys-Dietz syndrome or Loeys-Dietz-like syndrome. And these are the ones that I'm really going to focus on through the course of the talk today, because we know a lot about the management of these conditions, and we know that people with these are at high risk for aneurysms and dissections. And then we have this group of nonsyndromic aneurysms and dissections, the most common of which is ACTA2, and then there are others as well we will discuss a little bit. So why should genetic testing even be considered? Well, in some cases, it's really helpful to actually confirm a diagnosis. Certainly, Marfan syndrome is the thing that most individuals think about when they think about the genetics of aneurysms. And oftentimes, we have clinicians who are very good at identifying Marfan syndrome. Those in genetics and cardiologists and surgeons often are very good at identifying who could have Marfan syndrome. But sometimes these other conditions have such overlap that it is hard to distinguish if somebody has Marfan syndrome or Loeys-Dietz. And then genetic testing becomes more important as well. And that really is important because they are managed differently. The medical management is different for somebody who has Loeys-Dietz syndrome versus somebody who has Marfan syndrome or Vascular Ehlers Danlos syndrome. Certainly, the timing of surgery is different, and how we might treat them with medication or their risk of pregnancy is different between these different conditions as well. And identification of genetic cause is actually helpful for the patient in knowing, if they want to plan a family, what their risk of having a child with the same condition is. And knowing a cause actually opens up other reproductive technology to a patient if a mutation's been identified as well. And we also use it to help identify who else in the family is truly at risk so that they can get the care that they need. So I like to illustrate these conditions by using cases. So these are all cases that I have seen in my own clinic, and we'll start here with a 54-year-old male who presented to one of our vascular surgeons for consideration of an endovascular abdominal aortic aneurysm. But his history was significant for having had a type B dissection diagnosed at the age of 51. And at that time, he also had a dilated aortic root. And he then underwent a staged elephant trunk repair of his ascending and descending aorta. So I am a genetic counselor. I'm not a physician, but through asking targeted review of system connective tissue related findings, I was able to appreciate that he did have a pectus excavatum, scoliosis, history of hernias, and macular degeneration. His imaging prior to the repair, of course, showed that his aortic root was 4.6 centimeters and then similarly dilated with the MRA, and that his descending aorta was 5.7 centimeters. And when we saw him, his abdominal aorta was still dilated. Obviously, it hadn't been repaired yet. He also had dilation of his iliac arteries. So we're getting a picture here of a man who has multiple arterial beds affected, and we're not sure what's going on. So that is why the vascular surgeon asked me to come and see him. We did have his CT reviewed, and he did have dural ectasia as well. So giving us a clue that this, could be something syndromic, some connective tissue type disorder, since there is weakness in the lining of the spinal column as well. So I took his family history, and his family history was also significant for having a father who had history of a thoracic aortic dissection. That is not what he died from at 83. He had that years earlier, but his father was 6'4" tall. And then, as you can see here, he had an aunt and a grandmother and a cousin who also had history of abdominal aortic aneurysms and dissections. So, we were thinking at that point, what were our leading possibilities? Well, this could be Marfan syndrome, but his physical characteristics didn't make us think that that was a good fit. His father certainly was tall and had a thoracic dissection, but it didn't seem to fit well for him. He did have history of dissection, so vascular Ehlers Danlos syndrome was certainly something we were still considering. And then we are also considering this possibility of Loeys-Dietz syndrome. So let's just review a little bit about Loeys-Dietz syndrome first, and then we'll go on to the other conditions. Loeys-Dietz syndrome is a compilation of cardiovascular findings, in particular aneurysms at the sinus of Valsalva, but really all of the arterial beds can be affected. So it is certainly something that we're looking for when we're thinking about Loeys-Dietz is, are there multiple beds affected? Is the aortic root affected? Is there any arterial tortuosity? Because that is something that we often see with Loeys-Dietz syndrome, particularly tortuosity in the arteries of the head and neck. So those are clues that can give us some suggestion that this could be Loeys-Dietz syndrome. And then there are other findings in the skeletal system and the skin that can give us clues as well. In particular, craniofacial findings in Loeys-Dietz can be particularly helpful. When an exam can be done, sometimes we see hypertelorism, proptosis, a cleft palate may be part of the history, or, kind of the mild version in an adult patient who might be assessed has a bifid uvula, as you can see in the image here. Sometimes they are not as obvious as this picture of the bifid uvula, but that is something that we look for in our patients to see if it's a clue in the diagnosis. Sometimes these findings can be extremely mild, and in particular, in this picture from the Loeys et al. Publication, this man, sometimes clues that we have are even asymmetry in facial appearance, asymmetry of the eyes, or sometimes even in the mouth, can give us a clue that there might be something different going on, that maybe we need to suspect a syndromic cause for the aneurysms and dissections. And then Marfan syndrome is likely what most people are most familiar with. It's a compilation of findings of aortic aneurysms, particularly at the sinus of Valsalva. And usually it starts at the proximal aorta. You might have mitral valve prolapse. About 50% of people with Marfan syndrome have lens dislocation, ectopia lentis. And then there can be a constellation of skeletal and skin findings with Marfan syndrome as well. In 2010, the criteria for Marfan syndrome really was revised, and it trying to be a little bit more user-friendly. The criteria was changed to reflect findings of the aorta, the eyes, genetics, and the skeletal system. So there are a number of ways you can get to a diagnosis, whether it be with aortic dilatation and lens dislocation, aortic dilatation and a known disease-causing mutation in the gene associated with Marfan syndrome called fibrillin, or a combination of aortic and skeletal findings, or you could also have eye findings and a known mutation in FBN1 that has previously been shown to cause aortic disease. So one of the big things that was different with this revised criteria is that it includes exclusion of other genetic conditions, again highlighting that there is a great deal of overlap with Marfan syndrome and other genetic causes for thoracic aneurysms and dissections. So this does certainly bring in sometimes the need for genetic testing to make sure it's not something else. And then the other thing to consider are these other Loeys-Dietz-like conditions. And now there are a number of genes. I included on this slide SMAD3 because it particularly has been associated with early onset osteoarthritis and skeletal and joint abnormalities. It was published that about 50% of people with SMAD3 mutations will have these early onset joint problems. But we do know that that can happen across the spectrum of connective tissue, patients with connective tissue disorders. So that by itself, shouldn't really be used as an indicator to just say that SMAD3 should be done, but it just gives us additional clues that if there is early onset joint problem or early onset osteoarthritis, that is kind of a clue that maybe there could be something else going on, a connective tissue disorder. In particular, with the publication of patients known to have aneurysms caused by SMAD3, the interesting thing about this was that they actually showed that the mean age of dissection was around 46 years, whereas with the publication of mutations in TGFBR1 and TGFBR2 causing Loeys-Dietz, that age was significantly younger. So again, it is showing that all of these things, all of these syndromic and non-syndromic familial aortic aneurysms and dissection genes are associated with a spectrum of disease. So back to this case, we actually identified that he had a mutation in the TGFBR2 gene. And as I've kind of alluded to, mutations in this gene have been described as in a number of different ways. It was first described actually as causing a Marfan syndrome-like condition, or Marfan syndrome type 2, where individuals had significant overlap with Marfan syndrome. And then it was described as Loeys-Dietz syndrome, with individuals having more systemic arterial disease and sometimes having very severe presentation even in childhood and having craniofacial problems, including craniosynostosis or cleft palate and other birth defects. And then we also had description of it as causing, for lack of a better term, a more mild condition where there weren't a lot of connective tissue findings, but people were having aortic aneurysms and dissections. So it fell into quite a large spectrum from, across the lifespan, including people having problems at very young ages to people having problems in adulthood with aneurysms and dissections. So we know that this is quite variable. And because of that, we can't just say that it only affects very young people. In this case, we have a 50-year-old who presented and, in fact, has this condition, no matter what term you use, whether it's Loeys-Dietz or familial thoracic aneurysms and dissections, is caused by TGFBR2. So there are now some published guidelines for following and managing patients with Loeys-Dietz or TGFBR2 mutations. And these, we actually have had more in recent years as well. And these are really targeted at making sure that we provide the best clinical care based on the genetic makeup. And these are really targeted at cardiovascular findings, in particular surgical intervention, at earlier stages and close follow-up. So in adults who have Loeys-Dietz syndrome or TGFBR1 or 2 mutation, certainly these guidelines are recommending surgical intervention at an earlier stage, particularly referral to a thoracic surgeon when the aorta is around 4 to 4.2 centimeters for consideration of surgery. And that would be in adulthood. And then in children, they recommend intervention. So now we do have some understanding of the best management for patients who have Loeys-Dietz syndrome or a TGFBR2 mutation. And these guidelines are really aimed at early surgical intervention and proper imaging of patients to make sure that they get the proper care. In particular, for adults, surgical intervention or referral to a thoracic surgeon should be considered when the aortic root is between 4 and 4.2 centimeters, so much earlier than in the general population, or even for guidelines associated with surgical intervention with Marfan syndrome. An earlier intervention also occurs or is recommended for aneurysms in the descending or abdominal aorta at earlier stages as well. And then in children, the timing of surgery is often dependent on the Z-score and the degree of craniofacial findings. In particular, there is a trend that you can see that in patients who have more craniofacial problems, their vascular disease may be more aggressive as well. But there is a concern for delaying surgery in children in the hopes of actually delaying it until the annulus is between 2 and 2.2 centimeters so that they can actually use an adult graft to repair the child as well. Other recommendations from these guidelines include additional imaging of the vasculature, including head to pelvis MRAs or CTAs, because of the risk for aneurysms besides in the aorta. And then we know that some patients have cervical spine instability and need to have flexion extension x-rays before the use of anesthesia to protect their neck as well. So back to this case. It's been a few years, and we're seeing the family back for evaluation and offering testing for his children. And at that point, we did identify that his 19-year-old son was positive for the mutation. And unfortunately, in the time between the initial diagnosis and family members deciding they wanted to undergo testing and evaluation, his younger brother had a type A dissection, and ultimately he passed away of a second event. He survived his initial surgery after the type A dissection, but died within a year later, possibly of another dissection. We do have a happier story. In the case of his son, we did identify that his aorta was about 4.2 centimeters at the root, and he did undergo a successful modified David's procedure for replacement of his ascending aorta. And then during all of these evaluations, our patient's older brother actually was being evaluated for an abdominal aortic aneurysm, and we encouraged them, his physicians who were in a different state, to actually evaluate his thoracic aorta, and he was found to have a 4.5 centimeter aortic root aneurysm, so he did have those both successfully repaired. So the second case I'd like to illustrate is actually a 51-year-old man who was referred following a splenic artery rupture, which was repaired with a coil embolization. Through his evaluations, he was also found to have celiac and SMA aneurysms and had dilation of his
ascending and abdominal aorta. In particular, his mid-ascending aorta was at the upper limit of normal to just above normal at 3.8 centimeters. He reported history of a bicep muscle rupture and self-reported that he had had 2 shoulder dislocations from trauma, that he had hypermobile thumbs and had easy bruising. In particular, he had frequent bruising of his shins, and it actually had left discoloration on his shins. And he had thin skin. And you can see in this picture, it's not a picture from this patient, it's from a different patient. But sometimes, just having a look at the skin on their chest and if there's visible veins, that can give us a clue that this patient might be a little different and there could be a syndromic cause going on. So in this situation, I then took a family history as well, and identified that his father, who was still living, also had history of aneurysms. He had had 2 abdominal aortic aneurysms and 3 popliteal aneurysms that occurred in his 50s. And this patient and his brothers had all been advised 20 years before by his father's vascular surgeon that they should get evaluated because this is something that could be genetic. So they actually came in knowing that this could be genetic. They certainly did not know what it was, but they knew that it could be genetic. So this patient was very open to learning more about that. Among the possibilities here we were considering were vascular Ehlers Danlos syndrome, given his splenic artery rupture and his multiple aneurysms, or Loeys-Dietz syndrome, given the fact that there were multiple arteries involved and that his thoracic aorta was involved, although it was mid-ascending, not at the root. So in this case, we actually came back with a positive finding for vascular Ehlers Danlos syndrome. Certainly, this case is a little bit atypical for vascular Ehlers Danlos syndrome, in particular that he presented in his 50s, and that there are 2 generations affected. Not that that doesn't happen, but often, we don't have 2 living individuals with this condition since life expectancy is reduced. And also atypical was the successful surgeries in 2 generations, that they didn't appear to be as associated with tissue fragility that we often see in vascular Ehlers Danlos syndrome. There was no history of organ rupture or other features that we often see in vascular Ehlers Danlos syndrome. These images were from the Shalhoub article talking about how mutation, knowing the underlying genetic cause, what mutation in the COL3A1 causes vascular Ehlers Danlos syndrome can actually be helpful. And it's not always apparent based on external findings how severe a particular individual may be, as all of these pictured individuals actually died from this condition. So in this particular patient, a COL3A1 mutation was identified, and it provides us a good explanation for the atypical nature of his case, because it actually is a null mutation, indicating that only half of this type 3 collagen is being produced. It results in functional haploinsufficiency, indicating that there's stable mRNA produced, but an unstable protein that is either likely unusable or the cell gets rid of that copy of the mRNA, so protein is not produced from it. We believe that this type of vascular Ehlers Danlos syndrome associated with null mutations is likely under-ascertained because of the atypical nature of the case, and actually by COL3A1 being on these large panels, we may identify it more because it might not be something that people were thinking about and just requesting call 3A1 be performed, but by it being part of a larger panel, we may be able to identify it more frequently. This is not something that can always be identified through other technology, where we used to do skin biopsy and collagen screening for vascular Ehlers Danlos syndrome. This may be something that gets missed, so that if there are more mildly affected family members and somebody previously had collagen screening, that may not have picked it up, but now sequencing technology might be able to pick it up. And we know that there is a great deal of variability associated with particularly these call 3A1 null mutations, and that there can be family members who are completely non-penetrant, meaning that they can have the mutation and not have a vascular event, but you can have other family members who have more severe consequences, including dissection or rupture. Whenever we think about call 3A1, it is not something that we always see dilation at the sinus of Valsalva. So if we're looking at somebody who has had multiple dissections, but their sinus of Valsalva is normal, then certainly vascular Ehlers Danlos syndrome should be higher on the differential. So on to the final case, case 3. This is a 33-year-old man who presented with severe back pain that was ultimately found to be a type A dissection originating at the aortic root. Prior to surgery, there was an echo performed that showed that his aorta was 5.3 centimeters. He did have some history of high blood pressure, but had no recent trauma. With the review of systems, we did identify that he had scoliosis. He was somewhat flexible in his knees. He had some striae, but it could be explained by weight gain, and he had some thin atrophic scarring. His family history was actually significant for a maternal aunt who had an aortic aneurysm identified. Actually, her aortic aneurysm was an aortic root aneurysm, and it had been prophylactically repaired at the age of 48. She had been evaluated, and a potentially syndromic cause was considered, and she had undergone testing for TGF-br1 and 2, which was negative at that point. So we did offer this man new genetic evaluation, since there were more genes identified after his aunt had been evaluated, and he was ultimately found to have an ACTA2 mutation. So one of these things that we do consider nonsyndromic. Both he and his aunt had some findings that overlap with a connective tissue disease. So this is where panels, again, are very helpful, because people can have connective tissue findings but not have one of these connective tissue disorders, because connective tissue findings like scoliosis, hernias, things like that are fairly common in the general population, so not always indicative that it has to be one of these syndromic causes either. So this is particularly why panels can be helpful for us. So ACTA2 mutations are associated with aneurysms and dissections. They do not have to only involve the root. They can be ascending aneurysms, but sometimes they do involve the root. We can also see patients presenting just with dissection. And in fact, a recent study by Regalado et al. Showed that the median age of diagnosis for a type A dissection was 36 years, and the majority of patients with ACTA2 mutations actually presented with dissection. And the overall risk of dissection in patients through the lifespan was about 76%. Patients with ACTA2 mutations are not only known to be at risk for aortic aneurysms and dissections, but there is a risk for brain aneurysms or a vertebral or carotid dissection, as well as risk for early onset heart disease and stroke. And this risk of heart disease and stroke is not due to typical risk factors like smoking and lifestyle factors, but in fact, it is believed that ACTA2 mutations cause increased proliferation of smooth cell muscles that lead to the occlusion. And there certainly are reported cases of very early onset stroke and heart disease, including early onset stroke as young as or at less than 20 years of age. Additional findings that we can see in patients who have ACTA2 mutations are that kind of lacy red pattern called levidoreticularis, or a finding of the iris called iris flocculi that you would need an ophthalmology exam for likely. We often also see bicuspid aortic valve and patent ductus arteriosus. So in looking at this family and how this genetic testing affected this family, we then recommended that other family members be evaluated for this ACTA2 mutation so that we could identify who else in the family actually needed evaluation. And we did actually start with his aunt just to confirm that we were dealing with the same situation in her, and she in fact was positive. By this 33-year-old man with the mutation, as well as his aunt with the mutation, we then knew that his mother was also at risk or had carried this ACTA2 mutation even without testing her. And then we also recommended testing for this 52-year-old woman's children. And we did find that 2 of her daughters had also had the ACTA2 mutation. They underwent further evaluation. We did identify that her oldest 2 children carried the mutation, and that her oldest daughter actually had an asymptomatic vertebral artery dissection identified through our screening, but that both of her daughters actually had normal aortas at this point, which we know happens because it is age dependent, and not everybody who has an ACTA2 mutation goes on to develop an aortic aneurysm. So there are other non-syndromic causes for ACTA2 mutation, which we're not going to go into at this point, but we do know that the most common cause is actually caused by ACTA2 mutations, and that accounts for somewhere between 10 and 14% of the non-syndromic familial aneurysms and dissections. MYH11 and MYLK11 also contribute to these non-syndromic ones. They appear to be much more rare. The MYH11 mutation in particular has also been associated with patent ductus arteriosus. So when that is part of the family history or the personal history, that is certainly something. ACTA2 and MYH11 are certainly things that you would want to consider. So I hope you can see by these cases illustrating that genetic testing can be helpful in working up an individual to know how best to care for them, as well as to help identify family members. And with that in mind, actually, there are some guidelines supporting genetic evaluation, and that really was from the task force in 2010, which indicate that ACTA2 sequencing is a reasonable thing to consider in individuals who have a family history of thoracic aortic aneurysms and dissections. Further, they suggest that sequencing of other genes could be considered when there are features to indicate other conditions. It's fairly vague, and certainly in 2010 we didn't have all of the genes that we have now, but there is some support for doing more evaluation. And they also recommend referral to a geneticist should be considered in patients with familial thoracic aneurysms and dissections. And that certainly can be done, as part of the overall clinical care for some additional guidance, or using them in particular to help facilitate the genetic testing. So just to wrap up, things to consider in particular when you consider recommending genetic testing or referring on to a genetic counselor or a genetics facility. In particular, young age of diagnosis, we tend to use diagnosis of a thoracic aortic aneurysm or dissection at less than 50 years of age, or truly at a patient who has a thoracic aneurysm and dissection at any age if there is a family history as well. And then if there are any of these connective tissue findings that might make you suspect Marfan, or maybe now one of these other connective tissue disorders, if there's a bifid uvula, or other cardiovascular findings. In particular, are there multiple aneurysms? Is there any arterial tortuosity or livedo reticularis, mitral valve prolapse, or patent ductus arteriosus? Those extra findings may now push you over to say, maybe we should think about, is this a genetic problem going on? So in summary, there has been a rapid expansion in the number of genes known to be associated with thoracic aneurysms and dissections. In particular, now the use of panels is very helpful due to the overlap in clinical conditions and allowing us to test for genes that maybe we wouldn't have thought of on our own either. And using this genetic testing, it can actually help you care for your patients who have aortic aneurysms to make sure that, if there's a risk for a brain aneurysm, that we get the appropriate evaluation. And if you're not familiar with how these patients should be managed, you should feel free to send them on to a geneticist or a center, a cardiovascular genetics center who has a great deal of experience in dealing with families with thoracic aneurysms and dissections. Thank you very much.